Anxiety disorders, panic disorder. DSM-4 diagnostic criteria. A. There are both 1 and 2 of the following. 1. Recurrent unexpected panic attacks. 2. Follows at least one attack for 1 month or longer, or more. A constant concern that there will be other attacks. B. Don't be upset about what the attack can cause or its consequences. Losing your mind, me. No obvious behavior change in relation to C. Attacks. The absence of B. Agoraphobia. C. Panic attacks do not depend on the direct physiological effects of a substance or a general medical condition. D. Panic attacks cannot be better explained by another mental disorder such as social phobia, specific phobia, obsessive-compulsive disorder, post-traumatic stress disorder or separation anxiety disorder. In response to staying away from home or close relatives, panic attack is not a disorder in itself, but a situation that occurs during the course of different diseases. It is the period of intense fear or discomfort when at least 4 of the following symptoms begin and reach their peak within 10 minutes. 1. Palpitations, heartbeat sensation or increased heart rate. 2. Sweating. 3. Tremors or shaking. 4. Being short of breath or choking. 5. Respiration. 6. Chest pain or feeling of trouble in the chest. 7. Nausea or abdominal pain. 8. Dizziness, feeling lightheaded, being much like falling or fainting. 9. Derealization, feelings of unreality, or depersonalization, separation from self. 10. Fear of losing control or going crazy. 11. Fear of death. 12. Paresthesia, numbness or tingling sensations. 13. Chills or hot flashes. Agoraphobia, anxiety to be in places or situations where assistance may not be provided or it may be difficult to escape if a panic attack or panic-like symptoms occur. Being alone outside, inside the house, being in a crowded environment or waiting in line, traveling by plane, bus or car can be counted. These situations are avoided or endured with intense distress or a person is needed. Epidemiology, etiology, 1.5 to 3.5% lifetime prevalence. 75% of patients are women. Genetic predisposition is important. There is CO2 hypersensitivity and hyperventilation, serotonergic, reduced efficacy, and noradrenergic, increased efficacy, dysfunction. Differential diagnosis, medical conditions, atypical symptoms such as vertigo, loss of bladder control, loss of consciousness and onset after 45 should suggest medical conditions. Tests such as thyroid, blood sugar, and complete blood count should be done, especially the cardiac condition. Psychiatric conditions, other anxiety disorders, artificial disorder, hypochondriasis, depersonalization, social, etc. Phobic states should be distinguished from depression. Treatment, drug, SSRIs, clomipramine, imipramine, benzodiazepines are effective drugs in panic disorder. With the sedative effect of paroxetine, it is advantageous to get urgent results. Depression and alcohol dependence are common in these patients. Since panic patients are very sensitive to drug side effects, the drug should be started with a very low dose and gradually increased. Duration of drug treatment, since it is a chronic disease in which panic is impaired, treatment should be continued for an average of 6-12 months. The relapse rate has been reported as 30 to 90% with drug discontinuation. Cognitive behavioral therapy, the patient's tendency to interpret bodily sensations incorrectly, disastrously, and incorrect beliefs about it should be corrected. Relaxation exercises and breathing training can be helpful. In the treatment of panic disorder, agoraphobia also improves over time, especially by going over it. Obsessive-compulsive disorder, it is the clinical picture in which obsessions and compulsions dominate the clinic. OCD is classified as anxiety disorders in DSM-4. In ICD-10, OCD is involved in neurotic stress and somatoform disorders, and is classified as anxiety disorders alone. Definition and clinical features, obsession, these are continuous thoughts, impulses or fantasies that come unintentionally and occur inappropriately and cause pronounced anxiety or distress. Compulsion, repetitive behaviors, such as hand washing, lining up, controlling, or mental actions, such as praying, counting, repeating words quietly, that a person cannot stop doing. The purpose of compulsions is to protect or reduce anxiety or distress, not to enjoy or provide satisfaction. 40% of patients have only obsession, 30% of them only compulsion, and the remaining 30% have both obsession and compulsion. The most common obsessions are transmission, 50%, suspicion, 40%, somatic, 30%, symmetry, 30%, aggressive, 30%, sexual, 25%, and religious, 10%, obsessions. In more than 70% of cases, 2 or more obsession types are combined. The most common compulsions are control, 60%, washing, 50%, asking, telling or praying, 35%, counting, 35%, symmetry and order, 30%, and accumulation, 20%. Infection, dirt and germ, semen, toxic substances, radiation, etc. can be worried about contamination. Doubt, generally associated with control supervision compulsions. Door, ironing plug, stove, pocket wallet. Those with aggressive and sexual obsessions are afraid that they will engage in such actions, such as killing her child, having sexual intercourse with her child, and seek assurance from the environment. Patients with symmetry and regularity obsessions have the idea that events or objects must have a perfect or precise symmetry in exactly the order they want. Somatic obsessions are most frequently associated with checking and reassuring rituals. Obsessions about the person's illness. Therefore, it is difficult to differentiate from hypochondriasis. DSM-4 OCD diagnostic criteria. There are obsessions or compulsions. Obsessions. 1. Repetitive and persistent thoughts, urges or fantasies that come unintentionally and are inappropriately experienced and cause pronounced anxiety or distress. 2. ND. Thoughts, urges, or fantasies are not just extreme grief about real-life problems. -3. One tries to ignore or suppress these thoughts, impulses or fantasies, or to neutralize them with another thought or action. -4. One sees these as the product of his own mind, not like thinking. Compulsions, L. Repetitive behaviors, washing, organizing, controlling, or mental actions, praying, counting, speaking some words quietly, that she cannot prevent himself from doing as a reaction or according to the rules that must be strictly followed. 2. ND. These are aimed at getting rid of the distress or reducing the existing distress or protection from the event or situation that creates fear. However, these behaviors or mental actions are either not realistically related to what is intended to be inactivated or protected, or are clearly too extreme. B. During the course of this disorder, a person accepts that obsessions or compulsions are excessive or meaningless. Note, this does not apply to children. See, obsessions or compulsions cause significant distress, waste time, they take more than 1 hour a day, or significantly disrupt one's usual daily work, professional, or educational, functionality, or common social activities or relationships. D. If there is another axis 1 disorder, the content of obsessions or compulsions is not limited to this, a eating disorder, trichotillomania, hypochondriasis, paraphilia. This disorder is not directly related to the physiological effects of a substance, an abusive drug or a drug used for treatment, or a general medical condition. Low insight. In that episode, most of the time, if one does not accept that obsessions or compulsions are excessive or meaningless, epidemiology, the lifetime prevalence of OCD was found to be 2 to 3% and the prevalence of 6 months was 1 to 2%. Average age of onset 23. A little earlier in men, 21 years, in women, 24 years. In 65% of patients. The disorder begins before the age of 25, but in 15% after the age of 35. There are data that OCD is more common in people with high socioeconomic and education levels. Etiology, psychodynamic factors, Freud, anal period or regression to this period. During the anal period, the child became able to use two opposing and impulsively loaded abilities, holding and unloading. Behavioral factors, obsessions are conditional stimuli. A relatively neutral stimulus is matched with events of harmful or distressing nature, and is gradually attempted to be associated with fear or anxiety through the process of reactive conditioning. Genetic factors, there is a five-fold increased risk. Sociocultural factors, it is stated in DSM-4 that a particular culture requires and that culture-specific rituals cannot be considered as an OCD symptom. However, OCD is diagnosed when these rituals are performed in places and times that are more extreme than other people from the same culture and that are inappropriate to cultural norms and cause disruption in social roles and functions. Neurobiology, basal ganglia, especially in the striatum, have metabolism and blood supply abnormalities. In some OCD patients, motor tics and faint neurological signs are more common. There are 0 kilobytes cases starting after head trauma. Sydenham chorea is more common in patients with TS and Huntington's disease, and successful results are obtained in the treatment of OCD with psychosurgery. Made us think of a reason. There are certinergic, especially, and dopaminergic dysfunction. Differential diagnosis, neurological, Tourette syndrome, other tic disorders, temporal lobe epilepsy, and sometimes trauma, and post-encephalitic complications. Tourette, characteristic symptoms are motor and vocal tics. 90% of those with TS have compulsive symptoms and about 2/3 of them meet the 0 kilobytes diagnostic criteria. Other psychiatric conditions, schizophrenia, obsessive-compulsive personality disorder, OCPD, phobic disorder and depression. It differs from schizophrenia by the absence of other schizophrenic symptoms, insight, and fewer symptoms. Other psychiatric conditions closely related to OCD are hypochondriasis, body dysmorphic disorder and impulse control disorders. All of these disorders have repetitive thoughts or behaviors. Treatment, pharmacotherapy, cognitive behavioral therapy are used alone or preferably in combination. Pharmacotherapy, clomipramine, 150 to 300 milligrams, day. SSRIs, they have generally become the first choice. Recovery may take 8-10 weeks, high dose is required. The addition of antipsychotics can be effective in resistant and poor insightful cases. Among the cognitive behavioral therapies, the most effective are the combined use of in vivo exposure and response prevention techniques. Course and prognosis, in 50 to 70%, the onset occurs after pregnancy, birth, and a stressful event. As the patients hide their symptoms, the application to the psychiatrist usually takes 5-10 years after the symptoms appear. There is evident improvement in 10 to 30% of patients and partial improvement in 40 to 50%. In untreated patients, the rate of improvement decreases up to 6%. Poor prognosis indicators, onset in childhood, bizarre compulsions or delusions, very heavy picture, coexistence of personality disorders such as major depression or especially schizotypal personality disorder. Good prognosis indicators, good job and social position, early recognition of the disease and symptoms in an episodic nature. Specific phobia, it affects at least 10% of the society. It is 2 times more common in women. Behavioral factors, learning to fear, have the biggest share. DSM-4 diagnostic criteria, A. Excessive or meaningless, pronounced and constant fear, starting with the existence of a specific object or situation, or the expectation of encountering such a situation. Meeting with B-phobic stimulus almost always causes an anxiety response, or panic that starts all at once. Note, it can be expressed as anxiety, crying, moodiness, freezing, and cuddling in children. C. Person knows that his Her fear is excessive or meaningless. Children may not have this feature. D. Phobic situations are avoided or endured with intense anxiety or distress. E. Person's daily routines, professional or educational functionality, social activities or relationships are disrupted or there is a significant problem. The duration of people under the age of FL8 is at least 6 months. It cannot be better explained by any other mental disorder such as panic attacks, OCD, post-traumatic stress disorder, egg-avoiding stimuli accompanying a severe stress factor, social phobia, egg-avoiding social situations due to fear of embarrassment. Types: animal type, it is intended for insects and other animals. Natural, environmental type, storm, high places, water, etc. Blood injection wound type, fear of invasive medical events and procedures. It is highly familial and generally accompanied by a strong vasovagal response. Situational type, presence in public transport, tunnels, bridges, elevator, aircraft driving, fear of closed places. Other, emptiness, full phobia, fear of fairy tale costumes, etc. Phobic disorders are very common mental problems. Generally, application to the physician is rare due to possible avoidance. Egg plane phobia, improvement with natural exposure. Behavioral methods, exposure, systematic desensitization, are effective in the treatment of specific phobias. Anxiolytic and antidepressants may generally be required in combination with behavioral therapy. Social phobia, social anxiety disorder, it is the third most common mental illness after major depression and alcohol abuse. The lifetime prevalence in the USA was 11% for males and 15.5% for females. Starting after 25 is rare. Moderate social anxiety is useful as it will prepare individuals for social situations. Shame can be said to be the most secretive and intense of human emotions. It is a chronic disorder. The average time is up to 20 years. It is divided into 3 types: specific type, diffuse type and performance anxiety. Main social phobia situations: speaking in front of the community, using the toilet outside the home, using the water when it is necessary to use it, eating in the community or drinking something, not being able to say anything, writing while watching someone, being in a meeting, class or party. The prevalent type is associated with earlier onset age, half begins before the age of 10, and more often with alcoholism than the specific type. In severe forms, it is difficult to distinguish between social anxiety disorder and agoraphobia. Anxiety disorder spread with social phobia shows 50% coexistence. Behavioral factors, unwanted social events, such as failure or humiliation in society, can lead individuals to fear and avoid subsequent social situations. The onset of the disease in half of social phobias is associated with such events. Embarrassing discipline by parents or cynical treatment of peers can also lead to similar conditioning. Observing the social anxiety or humiliation of others may also create conditioning in that direction in the observer. The contribution of genetic factors is up to 30%. While it has been suggested that there is an increase in adrenergic stimulation in limited specificity social phobia, some researchers attribute social phobia to dopaminergic hypoactivity. Serotonergic dysfunction, lack of social skills also plays an important role in the etiology of social phobia. DSM-4 diagnostic criteria: A. Feeling pronounced and constant fear of encountering unfamiliar people or being in the eyes of others, performing one or more social or actions. The person is afraid that he will behave in a way that will become minor or embarrassed, or show signs of anxiety. B. Facing the feared social situation almost always causes anxiety. It can be expressed as anxiety, crying, moodiness, freezing, and cuddling in children. C. Person knows that his fear is excessive or meaningless. Children may not have this feature. D. Feared social or situations where an action is carried out are avoided or suffered with intense anxiety or distress. E. Daily jobs disrupt their professional or educational functionality, social activities or relationships, or there is a marked problem. The duration of people under the age of 18 is at least 6 months. If so, please specify. Disseminated. If fears cover most social situations, consider co-diagnosing shy personality disorder. Performance: reading aloud in the classroom, music, sports, writing on the board, answering questions, taking tests. Interactive: participate in conversation, especially with the opposite sex, talk to adults, party, etc. Participating in school activities, asking for help, asking for dates, social avoidance, security provisioning strategies, ignoring, blinking, getting sick. Refusal to participate in contrasting, social activities, school refusal. Speaking without interruption if she has to avoid, speak. Discrimination with shy is a clinical reasoning problem. In general, shy people observe the environment and determine that there is no negative attitude towards him and that he does not seem stupid. However, because the social phobias focus on their own behavior, not the environment, they are not able to make such an assessment, or they make negative decisions without even seeing it necessary. Cognitive behavioral therapy, role-playing, audio and video feedback. It is important for the patient to follow his image and understand his negative judgments. It helps to adjust the tape tone. Relaxation training, reinforcement, family treatment, strategies to encourage entrepreneurship, quench anxiety, and assess parents' emotional and anxious responses, communicate and problem solving. Parent education, group therapy, benefits, creating peer support, modeling, reinforcing opportunities, normalization, sharing resources, helping behavior. Drug treatment, the average duration should be 9-12 months. SSRI, BDZ, clonazepam, beta blocker, propranolol, phenelzine. Long-term treatment studies revealed that only 11% of these patients recovered a year later. Common anxiety disorder, an extreme concern and delusional expectation that the person cannot prevent is the main feature of this disease. Its 1-year prevalence is 3 to 4%. The female-male ratio is 3/2:1. Etiology: neuroadrenergic overactivity is known to cause anxiety and fear. Increased activity in the neuroadrenergic system or changes in adrenoceptor sensitivity and GAD. It has also been shown to increase serotonergic efficacy and decrease in GABA efficacy. Biological research suggests that neural conduction may be impaired in anxiety-related areas of the brain, cortical structures, limbic system, basal ganglia and cerebellum. It appears that autonomic flexibility, which should normally be in stress responses, decreases. Although a high rate of GAD, such as 20%, near the first degree of patients suggests genetic etiology, the general opinion is that environmental factors are more important. He showed that timid, addictive, compulsive and low self-esteem characteristics are important predictive factors. Clinical features: it is described as inspiration in the society. There is an extreme measure of concern and delusion regarding the economic situation, possible job obligations, health problems, events that children may experience, household chores, repairs, lack of appointments. DSM-4 diagnostic criteria: A for at least 6 months, intense anxiety or anxiety about many events or activities, work, school, etc. B. The person has difficulty controlling his anxiety. See at least 3 of the following, only 1 for children. 1. Restlessness, overexcitement or anxiety. 2. Easy fatigue. 3. Concentration reduction, mind numbness. 4. Irritability. 5. Muscle tension. 6. Sleeping problems. The spiritual process that is especially important in GAD is the belief that the person has no control over the environment. The person constantly monitors potentially dangerous stimuli and does not take into account non-hazardous, pleasant stimuli. This is a mental mechanism that operates automatically and unconsciously in patients. As the person cannot stop his intense anxiety, he has difficulty focusing his attention on routine work and becomes distracted. Patients are restless, excited and impatient. The face and body are tense, hands often tremble. Head, back, shoulder aches and stiffness are common. Muscle tension is particularly intense in the forehead muscles. Complaints such as easy fatigue, dry mouth, excessive burping, difficulty breathing and swallowing, palpitations, frequent urination, difficulty in erection, tinnitus, dizziness, and numbness cause differential diagnosis problems. Differential diagnosis. First, it should be distinguished from normal anxiety. Anxiety in GAD is disproportionate, more common, more chronic, and less associated with stress than realistic, normal, anxiety. GAD can develop secondary to different physical diseases. Hypothyroidism, hypoglycemia, cardiovascular diseases, anemias, can be confused with COPD frequently. The association of panic disorder, major depression, alcohol dependence, social phobia and GAD is extremely high. Going and ending, GAD significantly impairs quality of life. GAD generally starts around the age of 20. In some patients, the symptoms persist throughout life, while others progress with exacerbations during periods of stressful events. Generally partial improvements are obtained. Treatment. It is more realistic to aim at reducing symptoms rather than aiming for full recovery. It is recommended to remove caffeinated substances, tea, coffee, cola, chocolate, which can increase anxiety. If used, theophylline, stimulant and decongestant drugs should be stopped with marijuana, alcohol and cocaine. Benzodiazepines. 70% improvement can be achieved with low and medium doses. Diazepam is the most commonly used benzodiazepine. These drugs should not be used for more than 1-2 months. Buspirone is an S receptor partial agonist. It is used in divided doses 2-3 times a day and in daily doses of 20 to 60 milligrams. Beta blockers, propranolol. It calms the physical symptoms of anxiety such as sweating, trembling, palpitations. Antidepressants. There are many publications on the effectiveness of tricyclic ADs. They are increasingly used in GAD, 50 to 150 milligrams. SSRIs. Behavioral cognitive psychotherapies. It is aimed to show patients their thinking and their disturbing function. Restructuring poor functional thoughts. Attempts to deal with it in real-life conditions. Besides graded homework, breathing training, muscle relaxation techniques are used. Post-traumatic stress disorder, PTSD. Post-traumatic stress disorder has 3 sets of symptoms: relieving the event, avoiding and overstimulation. It is the only mental illness with a specific etiological factor: traumatic event. War, earthquake and flood disaster, physical or sexual assault, theft, murder, motor vehicle accidents, concentration camp and torture, abuse for a long time are examples of such events from life. This disorder has mitra-related experiences, both anxiety symptoms and depressive symptoms. All PTSD symptoms may develop shortly after exposure to the traumatic event. Risk factors in the development of PTSD: suddenness, duration and severity of trauma, history of mental illness, neuroticism, introversion, lower intelligence and age, inadequate education, low socioeconomic status, ability to cope with limits, limited social support, starting treatment late. Epidemiology varies according to the stress intensity. Of course, mass disasters such as war and earthquake will undoubtedly be encountered much more often. Its prevalence in the general adult population ranges from 1% to 12%. PTSD symptoms are present in 94% of rape victims and 40% of war veterans. Biological factors: increased noradrenergic sensitivity, overexcitation, sleep problems and anger bursts. There is serotonergic dysfunction. Dopamine is especially important in the paranoid and other psychotic symptoms of PTSD. Brain imaging: by-in imaging studies have mostly revealed hippocampal atrophy, decreased blood flow in the Broca area, and changes in the ratio of thalamic, cortical activity. DSM-4 diagnostic criteria: Facing an atraumatic event. 1. The person has experienced, witnessed or faced such a threat, a real death or death threat, a serious injury or a physical integrity of himself or others. 2. Person's reactions include extreme fear, desperation or terror. Note: children can express their reactions with disorganized or agitated behavior instead. B. Traumatic event is repeatedly experienced through one or more of the following. The first incident, the annoying memory recalled without being obtained. Among them are fantasies, thoughts or perceptions. Note: young children can play games that deal with trauma itself or its different aspects over and over again. 2. Seeing the event in a dream, often in distress. Note: children can have terrible dreams without fully understanding their content. 3. The traumatic event involves acting or feeling as if it is happening again, even if it is about to wake up or drunk. It includes the feeling of reliving that experience, illusions, hallucinations, and dissociative flashback episodes. 4. Having an intense psychological distress on encountering internal or external events that evoke or resemble an aspect of the traumatic event. 5. To show physiological reaction on encountering internal or external events that evoke or resemble one aspect of the traumatic event. C. With 3 or more of the following: a constant avoidance of certain trauma-induced stimuli and a reduction in overall response. 1. Efforts to avoid thoughts, emotions or speech accompanying trauma. 2. Having activities that evoke memories of trauma, attempts to stay away from places or people. Not being able to remember an important aspect to the third trauma. 4. Significant decrease in interest or participation in important events. 5. Feelings of getting away from people or alienating from people. 6. Limited in application, unable to experience the feeling of loving. 7. Carrying the feeling that there is no future, expectation. Specific symptoms of increased arousal with the presence of 2 or more. 1. Difficulty sleeping or maintaining sleep. 2. Irritability or anger bursts. 3. Having difficulty concentrating their thoughts on a particular subject. 4. Hypervigilance. 5. Shooting an excessive startle response. This disorder, symptoms in B, C and D diagnostic criteria, lasts longer than 1 month. F. This disorder causes a clinically obvious problem or impairment in social, professional or other important areas of functionality. Acute, if it takes less than 1 month. Chronic, it takes 3 months or more. Delayed onset, if symptoms started at least 6 months after the stressor. Treatment, psychological interventions aim to help the patient assimilate the trauma experience. The benefit of returning the victim to the trauma site has not been proven. Prolonged exposure procedures, such as video exposure, exposure to traumatic objects, imaginative exposure, cognitive therapy, are useful. Systematic desensitization has been replaced by exposure therapy. However, drug therapy is still an indispensable tool. The most used drugs are antidepressants. Amitriptyline, 300 mg day, is superior to placebo. SSRIs provide relief of both positive and negative symptoms and are preferred treatment. Anxiolytics, alprazolam, buspirone, have been found useful. It can be used in MAO-resistant cases. Acute stress disorder, it has been used to describe early and normal responses to the traumatic event. In addition to PTSD symptoms, it also includes dissociation symptoms, blunting, reduced awareness of the environment, derealization, depersonalization, amnesia,